Hello, how are you? My name is Winnie Barawa. Welcome to our session on chronic obstructive pulmonary disease, normally known as COPD. For those who are watching me or watching this video for the first time, kindly remember to subscribe. Those who are returning subscribers, leave us a comment and how far our channel has been able to impact you in your learning and to impact you in your life. So in the chronic obstructive pulmonary disease, we will focus on the definition, the manifestation, pathophysiology, all the way to the management. So on definition, chronic obstructive pulmonary disease, or what we refer as COPD, is a disease that is characterized by airflow limitation that is not fully reversible. So this airflow limitation is normally described or prescribed to be progressive and is associated with inflammatory response of the lung due to presence of irritants or stimulating agents. So there's a very slow progression of the deterioration in terms of lung function for many years before development of the illness. So one of the reasons why COPD is actually referred to chronic is due to the long-term existence of this disease in the patient before you can see the symptoms or you can see any change in the status of the patient. So COPD is described to contain two illnesses, and in these diseases we have chronic bronchitis and pulmonary emphysema. So in the description of the two illnesses that comprise COPD, starting with chronic bronchitis is described as the chronic inflammation of the lower respiratory tract, which is characterized by symptoms of excessive mucus secretion, cough, and dyspnea, which is very common with recurring infections. And the biggest involved area of our respiratory system in this case is the lower respiratory tract. So with chronic bronchitis, the response of this disease is the aspect of inflammation that is happening in the lower respiratory tract. And in this case, we are talking about the bronchus, the bronchioles, all the way to the terminal bronchial areas. And in this case, we have cases of excess mucus being produced. There's hypersecretions of the secretions, and there's bronchospasms, and the airway generally tends to constrict and reduce in diameter, which tends to affect our breathing abilities, and that's why we're talking about dyspnea. But on the other bit of pulmonary emphysema, this is a complex lung disease which is characterized by destruction of the alveoli, also displaying enlargement of the distal airways and a breakdown of the alveolar walls. So the emphysema disease on this other side is a bit destructive with the presence of destructions of the alveolar walls, there's enlargement of the distal air spaces, and the alveoli are generally being destroyed, more so because of the extreme prolongation of the inflammation. Remember, this is a chronic illness, estimatedly at about 3 months and above, and with the 3 month symptoms or the 3 month characterization of this disease, you find that in some states the alveoli get damaged and the small airways get to be distended or they get to be over enlarged due to the weakening of these walls. So what could be the possible causes of COPD? So the commonest cause of COPD is described to be cigarette smoking. Reason being, with cigarette smoking, the composition of tar and nicotines, they are known to stimulate inflammatory responses, especially in the bronchial walls that stimulate inflammation, and on extreme exposures, it can lead to distractions and it can lead to over enlargement of these airways. However, other causes of COPD could be air pollution, that is in terms of occupational exposures or exposure to irritants in the environment. Then there is allergy or allergic reactions that stimulate inflammation in the lower respiratory tract areas and stimulate such cases. There is also autoimmunity. Then cases of chronic lung infections. We have also genetic predisposition to the antitrypsins what we describe as deficiency of alpha-1 antitrypsin. So to make this clear is when we describe antitrypsin deficiency, the main explanation is that trypsin protein is an enzyme that is responsible for digestion of proteins. Now, in the case of absence of antitrypsin, the alpha-1 antitrypsin, it means we are not able to control the digestive functions of the trypsin enzyme in our body. And this trypsin can end up destroying part of our lower respiratory tract walls. So with the genetic disorders which come with deficiency of this antitrypsin, then our patients become at risk of developing such diseases such as emphysema, which is destructions of the lower respiratory tract walls. And other risk factor can include aging, such that you're saying, in the case of aging, the patient tends to have lower immune system or lower immune status, and because of this, they are at risk of getting infections or constant infections. And with the existence of extreme infections or recurrent infections, our client is becoming at risk where we're talking about chronic lung infections. Our client can be at risk of damaging the lower respiratory tract airways, including the alveoli, and leading to development of either chronic bronchitis and including the emphysema. So this brings us to the pathophysiology of COPD, where we say in the pathophysiology, the biggest starting point is the exposure to the noxious particles in terms of either gases or other irritants like smoking and so on. So with the exposure to the gases or irritants, then we have the abnormal response of the lung and the lower airways to these agents, leading to inflammation reactions. So the response occurs mostly involving the lung parenchymas. It involves the lung airways and the pulmonary vasculatures or blood vessels. So this stimulates inflammation, what we are now describing as the bronchitis, and this leads to narrowing of the airways, leading to also mucus hypersecretions, and at the end of the day, we end up with the airway blockage. So the starting point is the irritants that stimulate inflammations of the parenchyma, airways, and the vasculature, which leads to production of excess mucus that is very gelatinous and airway blockage. So with prolonged exposure, we end up now with destructions of the airway that leads to the status that we are calling emphysema. So repeated infections to these areas, that is the alveoli and the lower airways, we can have now lung damage that can further complicate in a state we call fibrosis. So the pathophysiology, basically we can say we have presence of the pollutants or the irritants in form of either gases or other non-risk causative agents that can stimulate inflammation. And with the stimulation of this inflammation, then we have overproduction of mucus or hypersecretions of mucus. We end up with bronchospasms, and the airway can actually end up getting blocked or narrowed. But on the other side of emphysema now is where we lose elasticity of the airway walls due to the distractions, and this can affect the enlargement or the elasticity of the airways, and in the alveolar cases they get to be over enlarged or hyperinflated, and this client develops now the emphysema status. So this now asks for what are the chronic manifestations of COPD. Usually it's advisable when you're describing the symptoms, you take it as per the disease that you're handling at that time. Is it chronic bronchitis or is it emphysema? So in this case, I'll start by describing the symptoms accompanying the chronic bronchitis wave. So first, one of the symptoms of chronic bronchitis is that this disease is usually slow. It develops over a period of years, and in this case, we say the client can have presence of productive cough lasting at least three months in a given year for 2 successive years. And this is a very prolonged period of cough, like 3 months consecutively. That is a long period to be coughing. So there's productive cough lasting at least 3 months, but alongside this cough, there's production of thick gelatinous sputum. Greater amount are normally observed during infections or during the superimposed infections. And so this client has wheezes as lung sounds, and the patient also displays dyspnea or abnormal breathing patterns. So here is an illustration. This is a healthy lung. The lumen is widely open. The trachealis muscles are still intact, not inflamed, and the wall is basically well aligned and clear. However, in the bronchitis status, there is inflammation happening in the bronchial walls, and with this inflammation, the walls get to swell. We get to see hypersecretions of the mucus, and it's occupying this airspace, or it's occupying the lumen. But again, this is now reducing the airspace lumen. It's causing further blockage with the mucus thickening and occupying this space. So in the clinical manifestation for the bronchial side, mostly we tend to describe the inflammatory effects that happen in these lower airways. So we talk about the bronchospasm that comes with cough. We talk about the mucus that is gelatinous, but we also describe the wheezes and the dyspnea. And in the second bit, that is emphysema. So emphysema is described to be quite gradual, unlike what we saw in chronic bronchitis, that it's slow. So emphysema is very gradual in terms of onset and very steady when it comes to progress. So the symptoms we will observe with emphysema is we will have dyspnea, and then there's decreased exercise tolerance, meaning our client will have impaired activity tolerance. There'll be some display of fatigue, and there'll be that inability to withstand long, maybe standing activities or engage full activities. Cough is minimal, except though where there is respiratory infections, then this can be observed. But in observation, the patient also has increased anteroposterior diameter of the chest, leading to development of what we call the barrel chest. Basically, this is due to the air trapping. As you can see, our client with emphysema, because of the distractions of or damaged air alveolar walls, the alveolar tends to overinflate, that is over enlarge, because they have lost their recoil, they have lost their elasticity. So when the patient inspires or takes in air, the alveoli will enlarge to accommodate that, but they will not be able to recoil back to their normal sizes because they have weak walls and they have over distension at that time. So in this, we are comparing the symptoms between chronic bronchitis and emphysema. So we have observed that chronic bronchitis is more displaying about the inflammatory reactions that is happening in the lower respiratory tract, while in the emphysema, we're talking about the distraction that is happening in the walls, involving the parenchymas and the alveolar walls. So with the chronic bronchitis, we normally say there's mild dyspnea here, but in the emphysema, the dyspnea might be quite severe. However, with chronic bronchitis, there is productive cough, while emphysema can have dry cough or no cough at all. Cyanosis is very common with bronchitis, but the cyanosis status is very rare with emphysema status. But when it comes to infections also, infections are commonly observed in the chronic bronchitis, but infections are quite infrequent or not normally seen when it comes to the emphysema symptoms. The other bit is the age of onset. Chronic bronchitis common with people after 40 years of age, but emphysema usually observable after the year of 50 years of age. So the client with chronic bronchitis and emphysema have common history of cigarette smoking. So this means both of these illnesses can easily be observed in a client who is a cigarette smoker. And then copulmonal, which is a disease involving the heart, or respiratory diseases involving the cardiovascular system, we say is very common with chronic bronchitis, but in emphysema, you can observe it. However, we see it in the terminal stages of this disease when it's occurring. So these are common symptoms that you can observe. Some are similar, some are different or in contrast, and therefore you just need to understand what about cyanosis, cough, dyspnea, infection frequency, age of onset, history of cigarette smoking, and the complications to copulmonal. So this is the side of bronchitis, and this is the side of emphysema. So in all this, you can basically observe how these diseases progress in regards to symptom management and progress. So the other bit is, how do we diagnose chronic obstructive pulmonary disease? One of the best ways is to do arterial blood gas or determination of arterial blood gas levels, whereby we shall observe decreased partial pressure of oxygen with also low pHs and increase in the carbon dioxide levels. So with this basically shows we will see a status of acidity in our blood levels, and we will see observe increased partial pressure of carbon dioxide in this blood. The other bit is chest x-rays, whereby in the late stages we will see display of hyperinflation, particularly in the terminal airways, and then there's flattened diaphragm with decrease in vascular marking. Remember we said COPD involves the vasculature where it also gets damaged and blocked and the blood supply gets to be limited. Then we have pulmonary function test where we want to establish more so the aspects of airway flow or airflow. And in this case, unfortunately, there is obstruction that is observed and majorly due to mucus overproduction, which is blocking the airways. We have also the inflammation that is swelling these walls, and we have the cases of distractions also that are reducing the airflow into these spaces. And so with the observation of the pulmonary function test, we shall see forced vital capacities that is displayed by the forced expiratory volume of 1, all these ratios be getting reduced. So you will basically observe based on the ratios and based on the volume capacities that you are producing on the test. Then the other bit is participating in conducting what we call the alpha-1 antitrypsin assay, whereby we want to establish if there's the genetically predisposition into antitrypsin deficiency, which is a very important aspect when it comes to trypsin enzyme functionalities in our body. And so this takes us to how do we now manage COPD? So understanding that COPD presents with symptoms of blockage of the airways, it is important that you impose or you produce management that promotes airway clearance. And one of the ways is administering inhaled bronchodilators, which will help us reduce dyspnea and bronchospasm, either by using inhalers or using nebulizers. The other bit is administering inhaled corticosteroids, which are very important in elimination of inflammation processes. And good examples that you can use is the hydrocortisone or the prednisolone medications. And when it comes to chest physiotherapy, this is quite important because it can help us with postural drainage, consolidation of the secretions, and enabling the gland to cough these secretions out. There's need to give oxygen therapy for the client if there's any signs of hypoxemia and low oxygen levels upon doing the pulse oximeters or upon doing the lung function test. And not forgetting to conduct pulse oximetry, which is important in helping us monitor the oxygen level, monitor if there's any changes in our functionalities in the lungs, and basically seeing any progress for this patient. And we have the next management we can impose is control of infection through administration of antimicrobial agents in case you're worried about respiratory infections that we have seen in this disease is a trigger, but it's also one of the reasons for the recurrent cough and recurrent infection among chronic bronchitis. To prevent damage to the lungs, you need to encourage the client to quit smoking or any behaviors that tends to exhibit the symptoms and the diseases. Then there's need for treatment of the alpha-trypsin deficiency, preferably by administering IV exogenous supplements of antitrypsin, and this can be given, for example, via prolactins. And the last bit is lung transplantation, which is considered if there's severe incapacitation or severe disabling due to the alpha-1 antitrypsin disease. So in the cases where the congenital existence of the congenital deficiency of antitrypsin is too severe and the lung has been destroyed in totality, then we can encourage that we go for lung transplantation. However, it's good you initiate the other management before you you talk about lung transplants or replacement of the damaged lungs. And this brings us to complications of COPD. Complications can vary, but you can vary either way from aspect of respiratory failure. You can get pneumonia due to the overwhelming recurrent infections. And then we have right-sided heart failure and dyspnea. There's depressions and even skeletal muscle dysfunctions. Now, depression comes in as a mental health side effect, reason being COPD is a very long-term illness, and due to the extreme long-term exposure to these symptoms, the client can go through mental breakdown and depression due to the anxiety and unknown aspect of the disease outcomes. But the other bit is skeletal muscle dysfunction, whereby due to the extreme use of accessory muscles in the aspect of chronic bronchitis, our client then can end up with muscle weaknesses that can lead to further dysfunctions. So this is how depression and skeletal muscle dysfunction comes in. So thank you so much for participating in this class. Leave us a comment if this class was really helpful. Share this video with your community or your classes, and also with your friends who are learning the same aspect. Until we meet again in the next classes, bye bye.